Antonio Howard. I'm an assistant professor in the Department of Physical Medicine and Rehab. I'm sports med and physical medicine boarded. And today I'll be guiding you through the physical examination of the musculoskeletal system, beginning with the cervical spine. As always, our examinations begin with inspection. We want to look for symmetry in the case of the cervical spine, whether or not the shoulders are level, the position of the head and neck, whether or not the head is protruding or held in extension. And then we want to be careful to look from both sides and at the back as well to see that the spine runs midline. We're of course observing for masses or evidence of trauma or infection or inflammation such as swelling or redness. And then we move to palpation. Palpation of the spine involves palpating in the midline over the spinous processes, observing your patient to see if there's tenderness or complaints of pain, and on either side of the midline over the paraspinal muscles, and in the case of the cervical spine, the trapezius muscle, which is a common source for myofascial trigger points or tenderness in the muscles. Some attention to the anterior spine or the anterior neck is necessary, looking for things like goiters, lymph nodes, things like that, which can cause tenderness, swelling, or pain in the anterior neck. Range of motion in the cervical spine includes extension. Can you lift your head up? And the chin should point towards the ceiling for normal extension. Flexion, can you touch your chin to your chest? Come back to neutral. Lateral rotation, can you try to look over that shoulder? And again, the chin should be over the shoulder on each side. Come to this side. And back to neutral. And then lateral bending. Try to touch this ear to this shoulder. And on this side. It's important to know that patients will, you can relax, sometimes shrug to try to get or create the illusion of normal range of motion, and you should do your best as an examiner to prevent that or at least notice it when it's happening. The continuation of the cervical spine exam includes manual muscle testing, strength and reflexes for the upper extremity, which will be covered in a different segment. But special tests for the cervical spine, the main one you want to focus on is the Sperling's test. It's a neural compression test, and what we're trying to do is compress the nerve roots as it's exiting through the cervical foramen. To do this, you place the patient in extension, lateral flexion to the affected side, and then apply direct downward pressure, asking the patient, are you experiencing symptoms down your arm? No. It's important to note that sometimes simply positioning the patient in this position will create radicular symptoms, and if that's the case, there's no need to apply downward pressure. The examination of the shoulder joint begins with inspection, and we are looking at both shoulders for signs of asymmetry. We're assessing the muscle bulk to make sure there's no signs of atrophy, because very often patients will complain of shoulder pain even though the pathology is in the neck, for example with a cervical radic. We want to inspect the front and the back of the shoulders, looking at the position of the scapula. In this patient, you can see that the scapular is pretty well midline. Sometimes it's rotated out or winging away or pulling away from the thoracic chest wall, as is the case in winging of the scapula. When we're palpating for tenderness around the shoulder joint, we want to start at the sternoclavicular joint, anteriorly, palpate along the clavicle. At the top of the shoulder is the acromioclavicular or the AC joint. At the back of the shoulder is where we can try to palpate for tenderness at the glenohumeral joint, and then anteriorly over the biceps tendon. These are common places where patients might complain of pain or tenderness. Checking range of motion about the shoulder, it's important to know what the normal ranges of motion are. Full abduction will have the patient touching their thumbs at the top of the head. Good. This is also the position of full forward flexion. Turn your palms up and then lower them. And so this motion is flexion, but at the top of the head gives you full abduction and full flexion. bring your elbows down to your side, and you're going to go out. This checks external rotation. Most people should come almost side to side. But again, we're comparing the affected side to the unaffected side for asymmetry. Come back to the middle and then cross for internal rotation, and then back to the middle and scoot back for extension of the shoulder. When feeling for crepitus, you can place your hand right over the shoulder. That way you can feel the AC joint on the top and the glenohumeral joint, and passively range the patient's shoulder through abduction and flexion, and you should feel like Rice Krispies or bubble wrap popping underneath the hand that's on the shoulder. Special tests for the shoulder, the main one you want to be aware of is the empty can, full can maneuver. It's a stress test for the supraspinatus tendon, passing under the subacromial arch, or so an impingement test as well. And the way we perform this procedure is we ask the patient to get into what we call scaption, or abduction in the plane of the scapula, with the thumb pointing down towards the floor. And then the examiner applies direct pressure and asks the patient to resist. Don't let me push you down. In a positive test, the patient will complain of pain in the region of the supraspinatus tendon at the top or the front of the shoulder. And if he or she does, you ask them to turn their thumb up towards the ceiling to perform the full can test and apply downward pressure again. Don't let me push you down. And in this scenario, the patient should say that their pain is gone or not as severe as the first time. You can relax. Inspection of the elbow begins with the patient standing with the palms facing forward, so that we can have a look at the carrying angle of the elbow. For males, this angle is usually around 10 degrees. It's slightly wider, and females about 15 degrees. And it's important, as with everything, to look for asymmetry. That is a difference from side to side. You can have a seat. Inspection continues by looking at the antecubital fossa, where the brachial artery and the veins that are commonly accessed for IV access, where those run, to look for masses or bruising or evidence of infection or inflammation. And it's common for patients to have pathology at the medial and lateral epicondyles as well, and so we want to look for evidence of inflammation, if any, at those points as well. Swelling right over the olecranon may be olecranon bursitis or rheumatoid nodules, and so we want to inspect the olecranon or the posterior elbow for masses as well. Palpation in the elbow, again, seeks to identify tenderness at the lateral epicondyle, the medial epicondyle, and the olecranon. The radiocarpal joint can be palpated just distal to the lateral epicondyle, and you can supinate and pronate the elbow to feel the radiocarpal joint. Range of motion about the elbow involves flexion, and you can assist to try and get maximal flexion. Extension, so the elbow should go at least to, the arm and forearm should at least make a 180-degree angle. It's not uncommon for some people to have a little bit of hyperextension, especially female patients. The elbow also does pronation and supination. For full supination, the palm should point up towards the ceiling, and full pronation down towards the floor. The examination of the wrist and hand begins with inspection. You want to look at the attitude of the limb, whether or not the wrist is held in flexion or extension, radial or ulnar deviation, as these may be signs that the patient is experiencing pain in one range of motion or the other. You want to look for masses or swelling. Common masses around the wrist include ganglion, which are usually on the dorsal surface, but from time to time will occur on the volar surface. The Corvin's tenosynovitis is inflammation of the first dorsal compartment tendons, And so sausage-shaped swelling or redness in this area over the extensor tendons of the thumb may be consistent with this diagnosis. The arthropathies that affect the hand commonly affect the metacarpal phalangeal or the interphalangeal joints. Osteoarthritis and its Heberdine's and Bouchard's nodes will affect the IP joints. And rheumatoid arthritis may be associated with ulnar deviation at the MCP joints, mucoid cysts at the distal interphalangeal joints, and so these are things that we want to look for as well. It's important to look as well at the musculature of the hand, which can be atrophied in severe arthritic states, but may also be atrophied in neuropathies. So common neuropathy across the wrist, carpal tunnel, may be associated with atrophy over the thenar eminence, and ulnar neuropathies either at the elbow or at the wrist may be associated with atrophy of the hypothenar eminence, as well as atrophy of the first dorsal interosseous, both of which are innervated by the ulnar nerve. And palpation involves palpation of the wrist joint dorsally and on the volar side, as well as the MCP and IP joints of the fingers and the extensor tendons of the first dorsal compartment, which is the site of pathology in the Quervain's tenosynovitis. Checking range of motion about the wrist and hand. The wrist goes into extension, flexion, we're going to turn you over, yep, come back to neutral, ulnar deviation, radial deviation towards the radius, and pronation and supination. This motion of pronation supination is a combination of motion about the elbow and the wrist. And so deficits in pronation supination may be because of elbow pathology or wrist pathology. The fingers do flexion, and so patients should be able to make a full fist and cross the thumb across the fingers. Extension, abduction, so opening up the fingers, and then a deduction is bringing the fingers together. One final motion is opposition. That is the ability to oppose the digits, and you can ask your patient to simply touch the thumb to each of the digits individually. And that completes the range of motion examination of the wrist and hand. Special tests about the wrist are primarily for two diagnoses. The first is carpal tunnel syndrome, that is median neuropathy across the wrist. The median nerve runs in between these two tendons, palmaris longus and flexor carpi radialis. And so tapping over the nerve at the level of the wrist in patients who have carpal tunnel syndrome may reproduce tingling, numbness, or pain in the sensory distribution of the median nerve, that is the radial 3.5 digits. Similarly, if we ask the patient to perform Phelan's maneuver, that is flexion to 90 degrees at the wrist, and hold this position for 30 to 60 seconds, very often patients who have carpal tunnel syndrome will begin to complain of sensory symptoms in the sensory distribution of the median nerve. One final test for the Quervain's tenosynovitis is the Finkelstein's test, where the examiner tucks the thumb and ulnar deviates the wrist. This is passively done, so the patient does not do it, the examiner does it for the patient. And in a positive test, the patient will complain of pain along the radial side of the wrist, just over the radial styloid where those extensor tendons run. One derivation of this test involves the patient tucking the fingers over the thumb and performing ulnar deviation. This increases the sensitivity, but decreases the specificity of this test because this position is often painful in otherwise healthy individuals.